Just have a seat.
Ready?
Welcome.
Thank you, welcome. Yeah, absolutely.
We have, good morning, Commissioner Webb.
Thank you very much.
See you.
Okay, thank you very much. Thank you. Stephen? Thank you.
Good morning, Commissioner. Commissioner Lyons was on another call. He put his own meeting first.
Okay, all right. Commissioner Welles, are you back?
Good morning.
Good morning. Glad to, how's Colorado?
It's a beautiful morning today. It looks like it's going to be sunny and a little warmer than yesterday, so that's a start.
All right. Good.
I'd much rather be in Florida, trust me. It would just be easier if you guys moved these meetings out here. Everybody would be more relaxed.
Good morning, ladies and gentlemen. Welcome to the North Broward Hospital District Board of Commissioners Special Board Meeting. I'd like to call the meeting to order. John, would you please do the roll call?
Commissioner Rodriguez?
Here.
Commissioner Uri?
Here.
Commissioner Klein?
Here.
Commissioner Wellens?
It's okay.
Good morning. I'm here.
Okay. Commissioner Gregoire here.
Okay, Commissioner Uri, would you please lead us in the Pledge of Allegiance, please? I pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible,
With liberty and justice for all.
Thank you. John, do we have any comments from the audience?
No, sir, we do not.
Okay, thank you. Haven't heard none. Okay, we're in the second day of the candidate interview, and we have Mr. Joseph Gilene. Is that the right way to pronounce it?
Yes, Joe Gilene.
Yeah,
Yes.
because I
Yes, Mr.
seldom pronounce it the right way anyway. But so thank you very much for being here. We have Commissioner Gregoire, Commissioner Uri, Commissioner Klein, and then Commissioner Weller, our legal counsel, Ms. Barrett. We have Alan Goldsmith, our CFO, is that what you call it? And then our HR person, Peter Nyamar. And we have Joanne up there doing her thing. So, first of all, we want to thank you for having the patience and the perseverance to wait almost close to, I don't know, 9 months or a year, maybe. I lost track.
That's actually all part of the interview.
Yeah, yeah.
So more of attrition.
So anyway, I want you to know that there were over 300 candidates, and we received a list of the 10 most wanted, and we selected 6. One is employed, the other one withdrew his name, and so you are one of the 4 that are remaining candidates. Hope that soon we be able to make a decision and pick one of you guys to lead this hospital system. What I'm going to do is I'm going to first let you do give you about 5 minutes or so to do your opening remarks. Then what we'll do is we'll go through, I'll ask commissioners that have any questions. After those questions, you can tell us what your vision is and sell yourself. You know what I'm saying?
Yes, I do.
And then I would probably do another round of questions and do your closing remarks. Is that okay?
Yes.
So you're on.
Thank you very much. And good morning. I would like to express my appreciation to be invited to interview for the CEO of Broward Health. The residents and visitors of the Fort Lauderdale area and the region are indeed fortunate to have Broward Health serving their healthcare needs. You have a long history and are well respected and well recognized for the care that you provide. I'm impressed by your mission of providing quality care to the people you serve and a vision to be world-class, and supporting the needs of physicians and employees. I always look to the mission and vision of an organization to understand its passion. I have the same passion, and this is a system that I would be honored to lead. I've had the privilege of leading a number of organizations in my career. I am proud, so very proud, to say that we have made incredible accomplishments that made the health system stronger, allowed them to increase the number of patients that they serve, significant community benefit, significant economic benefit for the city and the county, improved quality, safety, patient experience, and was a visible icon in the region for the care we provided. As CEO, I would bring 30 years of healthcare experience in leading large and small hospitals and multi-hospital systems. At Quorum Health Resources, I managed 12 hospitals with a budget of well over $1 billion. At Catholic Health Initiatives, multiple hospitals in that market, we had a budget of well over $1.5 billion. I managed hospitals as large as 900 beds at the Carolinas Medical Center, 600 beds at Sacred Heart Medical Center, as well as Robert Wood Johnson University Hospital with budgets of well over $1 billion. I would bring experience in complex teaching and academic hospitals and health systems. Examples would be Robert Wood Johnson University Hospital, Sacred Heart Medical Center, Carolinas Medical Center, University of Louisville Hospital, as well as Jewish Hospital, all with very large teaching programs and well respected in the community. And also from a complexity standpoint, these hospitals had case mix index, which measures acuity of 1.6 to 2.3. This tells us that they are very, very sick and complex patients. I would bring experience in safety net hospitals, given that all of the hospitals I've managed were safety net hospitals. I would bring experience in integrating hospitals and outpatient services with the physician and the team into a true integrated delivery system that creates a shared culture and a focus on the patient. I would bring experience in both adult care and pediatric care. Not only the hospitals that I've already mentioned on the adult side, but I also had experience from Cincinnati Children's Hospital, well-respected pediatric hospital. I would bring experience creating service lines to unite clinical services, providing physicians and the care team together to improve care across an entire system. Noteworthy was the work that we did at Children's Hospital in Cincinnati, Robert Wood Johnson Health System, Carolinas Healthcare System, and Catholic Health Initiatives. I would bring experience in strategic planning. I will work with the board, physicians, and the team to develop a strategic plan and execute it. In our strategic plans that I've been part of, we were successful in improving operations, quality, safety, patient experience, and financial results. I would bring experience in growing a system. I led hospitals and systems to grow overall well over 5%, and in some clinical areas even more. First, and above all, you have to look at your process and your throughput. We've made some significant improvements into the care delivery system by decreasing ED wait times and time to see providers by as much as 30%. In the operating room, we actually looked at first case starts as well as time between cases, decreasing by and improving by 25%. I would bring experience in a system under a corporate integrity agreement. At Catholic Health Initiatives, a year before I joined in 2013, there was a compliance issue, and they too were, our system was put under a corporate integrity agreement in which we lived under. I would bring experience in not-for-profit as well as for-profit systems. All the hospitals that I've managed were not-for-profit, but at Quorum Health Resources, they use for-profit management, monitoring, and accountability to manage non-for-profit hospitals. I would bring experience in improving clinical care and care delivery, at building strong clinical teams to improve quality and safety, providing comprehensive monitoring and dashboards to oversee the progress. Even at Catholic Health Initiatives, we had to rebuild the whole quality and safety department because it was more of a tallying department than one that had a priority of improving. I would bring hospital recognition, and I think that's very important as we, as an organization, are competing with other health systems. We've achieved in that recognition and accreditation not only the Joint Commission hospital accreditation, but also the Joint Commission specialty designations in stroke, behavioral health, advanced comprehensive stroke care, ventricular device care, also accreditation in trauma, chest pains, Commission on Accreditation of Rehab Hospitals, and Commission on Cancer. We also brought recognition in the insurance market in very premier networks like Blue Cross and also United. U.S. World Reports also recognize us as a top hospital in various specialty areas, and very proud of winning awards for 90+% for patient satisfaction. I would bring experience in building relationships because I think that's really important for the CEO and the community, with the board, with the employees, with the medical staff. Experience in capital campaigns, in major gifts. At Cincinnati Children's, we won the Institute of Healthcare Improvement Pursuing Perfection Award, which we were very proud of. Or also in construction projects, projects as much as $120 million. I would be involved in the community, and I think that's very important for a CEO. Such organizations as Chamber of Commerce, hospital councils, the system and health foundations, community foundations, healthcare organizations and associations, and other community groups, all to bring visibility to the health system. And as CEO, I would bring a relentless passion on improving and driving success to achieve the best in healthcare. Commissioners, this is the kind of leader I am. I care deeply for our patients, our families, our employees, and our physicians. I believe in excellent communications. Our team needs to know where we're going and understand the role in getting us there. I'm a huge Jim Collins fan. I don't know if you're aware of the books. Good to Great, Built to Last, and Great by Choice. He speaks of the flywheel, the momentum of the flywheel moving in our favor, hurling the flywheel turn by turn. The good, great companies understand a simple truth. Tremendous power exists in the fact of continued improvement in the delivery of results. We need to have our entire team pushing the flywheel in the same direction. This will only happen if our team understands and knows where we're going and how we're going to get there, and importantly, is what their role in getting us there. I believe a leader must have character, credibility, integrity, honesty, and a vision to see their organization move forward and become that, as your vision has, a world-class organization. As you well know, we are in an ever-changing healthcare environment. We need to be top of our game and meet the needs of those we serve. I have extensive experience and leadership skills that I would, given the opportunity, bring to Broward Health. Thank you for the opportunity to introduce myself to you.
Thank you. Commissioner Gregg.
First of all, you say Gilene, is that how you pronounce it?
Yes, yes,
Gilene,
Commissioner.
welcome to sunny South Florida. First of all, thank you for coming to visit us. You mentioned that you worked with the corporate integrity agreement. Was that at St. Joseph's?
No, that was at one of the smaller hospitals, part of the St. Joe system. That's correct.
How many years was the agreement?
5 years.
5 years. And you understand we're also...
Yes, I do, and that's why I brought it up. I did get a chance to look at your corporate integrity agreement. It parallels very closely to the one that we have, and certainly I think it's a different environment, and you have to have experience in knowing that particular kind of environment. I understand that it won't be until August of 2020 before it ends. You have to
Some of us may end before that.
and we hope.
No, I'm looking at myself. You mentioned several times patient satisfaction. How did you gauge patient satisfaction? Was that a percentage?
That
Survey?
was age gap scores that we used, organizations such as Press Ganey and other rating agencies to measure our satisfaction. We did have another method, because age caps is just specifically inpatient, another way to gauge patient satisfaction on an outpatient basis. We looked at it each hospital and also used that as a gauge of how we not only make managers, like nursing managers, clinical managers, accountable for their unit and their satisfaction, but also guiding the organization to improve.
You mentioned safety net. One of your hospitals was a safety net. I don't know what that means. Could you tell me?
Okay.
I'm new at this.
Oh, absolutely. And I would say is that most of, if not all of the hospitals that I manage for safety net hospitals. What that means, and something that as a public hospital system, that you are a safety net hospital, meaning that your focus is specifically the community, having a higher standard for meeting the community's needs, and you are responsible for making sure that the community, through community benefits, are actually meeting the needs of the community you serve. So what's saying is that this organization stands ready to meet all of the community's needs, or using community partners to do so.
Which is a perfect segue into my next question. Much of our community is minority community, and we serve that community. Many of our African American leaders are sitting right behind you there, and I'd like to know how you interface and interact with that community, those communities.
Well, I believe first and above all, you build relationships. And I think, as a CEO, as a health system, building those relationships don't just happen by chance. It's a relationship that's built over time. It builds on trust, confidence, relationships, meetings with their communities, whatever that community may be, to gain an understanding and to also have trust between the organization. I think that's really important, and I think that helps in situations where, what are the issues before the community and the health system, understanding them. And I like to first always say, listen and understand, and then work with the community to actually look at how do we address the concerns that are present, and how do we build a relationship long term.
Would you go out into the community?
Oh my
to
gosh,
meet
yes.
with the community leaders?
Absolutely. No, and maybe I didn't say it in
Big
my
county, you'll be in the
introduction.
car a lot.
Yes, absolutely. I mean, I think that the worst, you can't be a CEO and just live in your office. I want to be visible. That means that you are in the community with community leaders, in the community with community partners. Understand, it takes a village to make a community healthy and keep it well, and make it an organization that is fulfilling the community's needs. You can't do that in an office. You've got to have a personal relationship. The community needs to know you. You need to know them. You need to understand what's important to them, and how to work together to resolve any differences that exist. I think that's important, and I think whatever community that might be, that's so crucial to have that trust and confidence and ability to work together to resolve issues.
And then my final question is, how do you relate with the press? How do you deal with the people who give us either good or a bad reputation out there?
Well, we've had similar situations in health systems that I've been with in the past where the relationship with the press or the media has not been good. And what we worked on is first setting forth I think an important foundational comment is, the media, the press are very important for us to be able to talk to our public, to the public. And our relationship is so important. Things that we did was we met with the local media and local press leaders to start that relationship. Everything is built on relationship. And if you don't establish that relationship, it starts off with one party not knowing the other party. So you start off with, and get out of your office and go and meet with the media and the press leaders. You talk about how you're going to be transparent, how you're going to meet their needs and the important role they play in educating the public. That's a relationship, and that is a proactive way of actually using and working with the media to get the message of this healthcare system out to the public. The other thing we did with our press and the media was to do proactive steps. Oftentimes, what seems to get in paper if you don't take actions, proactive steps, is when something is wrong, it then gets publicized. I would say in total confidence that there are wonderful things happening every day in every one of the hospitals that you govern. Incredible things, patients that are getting incredible care, life-saving procedures that are being done, patients and families that we are taking incredible care for. We would actually do stories and proactively send it to the media and the press so that they can actually know what we're doing. We give them access, of course, with patient and family permission, to actually interview those individuals so they can talk about the incredible care that happens every day here at the system. It's a relationship, and it's one in which you've got to build trust, confidence, and a partnership in each of the organizations, the press, and the health system's roles in the community.
Thank you, Mr. Gilene.
Thank you.
Okay, Joe, Commissioner Yuri.
Welcome.
Thank you, Commissioner.
Public tax supported hospital system. I'm on it, okay. As you know, that's how we're structured. That's how we would like to keep it. But what I'd like to get from you is a little understanding of what you see in terms of the virtues and challenges of a hospital system structured in that way, where our shareholders, our constituents, are the community. That's who we answer to.
I'd like to think that is a higher calling or a higher responsibility, and I think that's where, I've talked about in the safety net hospitals. Oftentimes, almost universally, from my experience, safety net hospitals are hospitals that are public, that are tax supported, often treat a disproportionate number of the underserved and undercovered patients in the community. That's an important role that the citizens of this county feel very important to them, so that everyone, and let's be honest, we're all trying to raise the quality and the status of healthcare in our community. And this hospital is one of those avenues that essentially the government, the taxpayers actually see as very important. I think it creates a lot of responsibility It requires transparency. It requires the organization to be very upfront with how it's using its dollars. It creates a needed understanding of how those dollars are being spent for every service that are being done. In fact, that was the whole point is you well know that non-for-profit or tax-exempt organizations must approve in community benefit. Community benefit for a tax-supported organization, in essence, puts that community benefit report and that information more loudly in the community's hands. I think the community is willing to support organizations that are meeting the needs of the underserved and the undercovered individuals and making sure that all of the services that are really important to the community are being fulfilled by this tax-supported organization. The other responsibility is to use those funds wisely. And that is something in which, as a taxing authority, you have the authority and the CEO and the system must absolutely demonstrate that the dollars are being used in a worthwhile basis. I understand the last financials showed about $137 million. That's a sizable contribution to this organization in order to fill its need. I think as CEO, and I'm sure Mr. Goldsmith believes this as well, it's very important that we do what we can to make this organization efficient, productive, so that we're not using as much of those dollars as what is given. That's a responsibility that the organization has, again, to use those funds wisely, and also is that to find ways to make the organization continue to serve, but then also in an efficient way, not to overuse or not to use those funds in any other way other than to meet the needs of the population. So in summary, organizations, public hospitals that are taxpayer support carry a real high mission for the community, a responsibility that has to take very seriously and be accountable to the public for those funds.
Thank you. You had, in prep for today, in reviewing your resume, I noticed at least there seemed to be some frequent moves, and I don't know about anybody else on this panel, but this isn't how I look forward to spending my week, okay? But it's a huge responsibility. And so trying to understand your level of commitment when you accept a position, putting a CEO hat on and having some type of a vision isn't a 2-year vision or a 3-year vision. It's a considerably longer term vision. Can you shed a little bit of light on that issue with respect to the different positions that you've had?
Well, I am very proud of my career. I've been in incredible organizations, worked with incredible board members, met the needs that each of the organizations had of the position in which I held. I took that very seriously and met that or exceeded what they asked me to succeed at. Each step in my career was increasing role and responsibility. I would be at Catholic Health Initiatives right now with the unfortunate situation of that organization deciding to sell hospitals, much like you see CHS and Tenet doing, and I'm sure you know about that. I go in with the commitment to meet the organization's needs, and I will be here as long as you allow me to be CEO if I'm so fortunate. You have my commitment that I do not want to be in a situation where the organization, changes the CEO. I will commit to being that individual that is the leader of this organization and be here as long as you allow me to serve.
Okay, thank you. I didn't mean it to
No, I
suggest that there's something wrong with your, I just want to, understand,
Very
what
valid
leads
question.
to these things. Okay?
Yes.
So with respect to operating under a CIA, which is, as you know, a challenge, what were some of the specific issues that you ended up having to overcome? And did you have any, throughout that period of time, issues, for example, that might have risen to the level of, a reportable event, for example, under the CIA? Like how did you handle those situations? And if they're not public, you don't need to tell me what the situation was. I'm a little more interested in how you, as a leader of the organization, managed through that.
Certainly. That is, just to describe the arrangement, is that the CIA, 5 years, they require extensive education and training from a compliance standpoint. So we've done that. Hiring an IRO, as you well know. We had to significantly increase our compliance staff, our compliance policies, code of conduct. We did not have CMOs at every organization, so that was required. We had to create specific guidelines and processes around physician contracting, create a process with the IRO to, in certain specifics, 100% audit to others, sample audit of various aspects of physician dealings. Understand this was a situation that involved our cardiac service line and charging. Since what I'm telling you all is never confidential or proprietary at all. All this is printed in some paper or an announcement, so I'm not telling you anything that you would be confidential. It changed specifically, significantly, the way we contract with physicians. Did we have situations where we found that there was a lack of a contract or lack of a detail in a particular contract to cover a particular physician service that should have been in a contract? Without a doubt, the larger the organization, the more chance that those situations might occur, or with no fault of anyone, have a situation where, and again, I'm not telling you anything that is that confidential, is, a physician office actually then took an extra office in the same suite. Well, it would be enriching them beyond which the contract specifies. Those things will happen, and what we did, I believe, uncovered and continue to add the necessary compliance level that made our leaders understand and our physicians understand what was important and how we needed to act and react in situations that might be perceived as a violation, or in situations are a violation. But I think, the larger the organization, the more apt that this happens. Whether you're under a CIA or not, there are situations that you got to do the right thing. You got to jump in, you got to disclose as your CIA so dictates. But we had a good relationship with the IRO. The IRO felt like the situation was resolved. We were transparent with them. We never really had an issue of compliance with our policies or with the CIA.
Great. My last question is just, it's a dynamic industry. Obviously, it's changing in many ways. Some of it at the whim of Washington D.C. But
yes.
Briefly, I guess what the biggest challenge you see this industry facing today, and the biggest opportunity that you feel is to be seized.
What I did was in preparing, and I try to coach and communicate with our leadership, and I actually put together a list of the challenges that we face. I would think that of looking at all of them. Some of them are financial, some of them are operational, some are HR issues, shortages, and there are many, many challenges that we have as an organization and as an industry. I think the one that rises above all of them right now is certainly, and if I can do a couple as opposed to just one, I think Washington is probably the biggest area where we are watching, is the Accountable Care Act going to be retained? Is it going to change? We already had a chip against it with the tax code, eliminating the individual mandate already. How's that going to impact? The fear is that clearly we're going to have less recipients of Medicaid, the expanded Medicaid program, so that's really a concern. State programs and state expansions, that really is part of that, and are we going to have the ability to continue to serve the population, or are we going to have to find other funding methods, because that has a significant impact on us. The other one that I think raises to that same level is we're in an industry that's changing. We are, I know you're a financial services executive, you provide services and you get paid for those services, as is most industries. If you look at that, this industry is that way. Patient comes to our emergency department, comes to our surgical center, comes to our outpatient center. We then charge for those services that are provided. As we move towards a different payment method, much more value-based, so value-based purchasing, again part of the ACA, we are already not only seeing the CMS, Medicare, changing their payments to us in the way they change us, and holdbacks and penalties. We're also seeing commercial payers doing the same thing. What that comes down to is more risk, and also more reward if we are able to meet quality and safety parameters, in which we should be doing anyway. So we're in an industry that, will it go to complete population health? I think we all dream of a time that we get to that method where concentration is on wellness, health, and the status of health of our community. That's where we need to go. That's going to create a different need for a different payment method. That's going to require that we look at the risk, the reward. How do we prove value for our organization? So clearly, I think those two, with changes in Washington and the state, to changes in how we're paid, how value is then calculated in our payment schedule, how we're moving towards a more of a population health or wellness kind of health system than what we have today. I think those are the ones that are confronting us the most, and ones that we have to be taking efforts now.
Great, thank you.
Okay, I'm going to go around to all the commissioners, and I'll be
Certainly.
last. Commissioner Klein.
Thank you, Mr. Chairman. Good morning, Mr. Gilene.
Good morning.
Thank you for joining us.
Thank you for inviting me.
Since a lot of these areas have already been covered in terms of community engagement and corporate integrity agreement, I'm going to focus on some new areas. Generally speaking, you've got an extensive background, most recently as CEO of a hospital system. And just generally, I wanted to ask you what similarities you see between your most recent role and the incoming role as CEO in terms of the systems and the differences as well. So how transferable would your experience be in this in the role of CEO of Broward Health?
I think one of the things that attracted me was the similarities. And you can imagine in my introduction, I tried to articulate areas where I see a lot of parallels in my experience to the system that is here. So I see from size to operations to complexity to being a public hospital system, meeting the needs of the community, to some of the issues and challenges that we all have, not only the CIA, but also is that some of the challenges of improving our clinical delivery system. In my concluding remarks, I'll talk about our patient and family focus that needs to improve. I really feel that there is a significant amount of similarities in I actually placed all of the numbers against where I am today and also where I was at Quorum Health Resources, and it's almost a carbon copy of size, complexity, teaching hospital, adult pediatric, all the areas in which I have experience in are ones that are a carbon copy to what I see is the needs of this organization. So much so is that, as I took the market CEO, market president position at Catholic Health Initiatives, I came into the same situation that this system finds itself. There was no stability at the CEO level. For the 5 years before I joined and became the CEO of the market, there was not a CEO that had more than a 1-year tenure. And what the challenges.
The 5-year period?
5-year period prior to my joining, there was never a CEO that held the seat with interims, with people that are spending time in consulting, coming in as individuals that speak to, yes, I have the experience, and they were placed in the role, but none of them were there more than a year. That takes a toll on an organization. And so that's another experience that I had that was just, I think that's what's attracted me right from the very beginning, to say this is a system that I would see as very similar to what the experiences that I had, as well as the skill and expertise that I've developed from those organizations.
Now, since you've done that analysis, what differences did you identify?
I would say is I was going to make a joke like as warmer weather, but very little in the way of differences. I've had experience with public hospitals and county-owned hospitals. I don't see anything that would be glaring issues that would be so different here than my last 2 positions, and the skill, the experience, the expertise that I used in managing those organizations. I really don't see anything that is so different. The only thing I can think of is your emergency departments with close to 300,000 visits is probably higher than what I have had in the past. I probably had more like about 150 versus 300. But that was the only stat that I saw that really was that much different.
More of a scale issue there.
And that was the only area. And I can understand. I mean, the role that you play here certainly is one, and the population that you have here is so much greater, so it's not surprising that emergency room counters would be higher.
Coming into any organization, you're going to have an existing or perhaps a lack of a pre-existing culture, and you appear to have a reputation as a team builder and as having a strong culture that you bring to an organization. So considering you're coming into another large organization, how do you accomplish implementing your culture and your approach without disrupting what's already there and causing, and specifically the impact on retention of existing personnel?
Sure. I believe that a CEO should not come in here and change the culture unless the culture is adverse to where the organization wants to go from a mission and vision standpoint. I mean, you've got a solid mission, you've got a solid vision. It is right in tune with where you want to go, is becoming a world-class healthcare or preeminent healthcare organization. What I would come in and feel very important to do is to make sure that that culture that's rooted by that mission and vision is being shared. Make sure that, and what I try to do is put a focus on the patient. How can we provide better care for the patient? And I work very closely with our CFO, and Mr. Goldsmith will probably look up, and I don't know how he'll react to this, but if we do the right thing, if we take great care of patients, oftentimes finances will come along, and with work that we would do, of course, to continue to improve it, the finances will follow, because people want to go to the best organization for their loved ones, for themselves. So I would say is that the culture, I'm not here to change the culture. I am here to make the organization more accountable, more disciplined, sense of urgency, focused on what we're here to do, and that's provide incredible care to patients. And in an efficient and productive way, using dollars wisely to actually make this organization great and raise the health status of our community. That's what we're here to do. Oftentimes what I find is that, and I'm not saying here because I don't know this, but I have seen systems that call themselves a health system, but they're still individual hospitals. It is rare for the hospital leadership to get together and talk about where we're going as a system, or that the employees see themselves as part of one hospital, not part of the system. They don't understand the benefit of being in a system. They don't understand the shared reason why we came all together and what do we do together. And I think that's the CEO failing, that we haven't moved to that. At CHI, Kevin Health Initiatives, we actually got an outside organization to outsource our culture awareness and create values and so forth. I'm not a big advocate of doing that. I believe that the right leaders, the right team members should come together and create their culture around the mission and vision about what we're doing, about doing incredible care to patients every day. That should be the culture that we have. But we've got to add what we think, what should be is healthcare as a business. We need to run it as a business, but it has a responsibility that precedes it being quote unquote a business. Because part of that business is providing incredible care. And that's got to be first, but then also is that we got to run this in a wise way. We do that because not only are we tax supported and we are accountable to the community, but also is that you are a governance committee that is responsible for the fiscal management of this organization, and I know you're taking that job very seriously. So I hope I answered your question.
Yes, you did. You actually answered my next question as well, so it makes it more efficient. Let me ask you, you mentioned in your remarks that we're in a competitive environment, and we absolutely are. There are other hospitals here providing levels of service that are comparable, so we need to compete to succeed. How do you envision that competition? How would you approach that competition, and include in your response, if you could, how you would approach recruitment? Because there's always going to be a certain level of attrition and loss, but how would you recruit doctors and executives and other medical staff to join the hospital system here?
Every environment I've been in, we had strong 1, 2, or 3 competitors that we had to address and see what they're doing and understanding the environment. some very strong, having, a significant market share than what we had. Some not so strong, and we were able to even make faster climbs in growth. Number one is those organizations are colleagues. Those organizations are much like this. They have a board. They're trying to do the right thing for their community. They have a CEO that would be my colleague, trying to do the very same thing, and they have incredible employees that are trying to do the very same thing. We're a community of organizations that are all trying to do the best for the community they serve. So the core services are exactly the same. What we have to do is rise above that and say, how are we unique? How are we providing services beyond what they do? I like to think that there's a great opportunity. How can we make our quality indicators and our safety indicators better than them? That's something that we can differentiate ourselves quite quickly with, like quickly relative, of course. You create physician champions and nursing champions, and your quality initiative needs to be a priority. So we got to raise. We can't be a C organization and leapfrog. We got to be an A. We got to be, a 1-star organization. We got to be a 3-star. No, we got to be even a higher star.
Yeah, I've noticed, if I can interrupt you there, I've noticed that you did improve your scores at your last position. How do you do that? I mean, what's your approach specifically in terms of procedures and processes to implement? And specifically, looking forward to here, what would you do here
Yes.
to achieve similar results?
And please hold me to answering the rest of your question too. But I would say is that number one, it's got to be a priority. We actually changed even our board report. The quality comes first in the board agenda because it says and sends a message. It sets a message that it's important, and we've changed performance evaluations. So Peter, the evaluation for managers, for leadership, even for employees, have an aspect and a certain percentage that is associated with quality and safety. My belief is that you got to come in and do a gap analysis. You got to look at where you are, what things or where you want to be, and then establish. And what we've done is we did a multidisciplinary team with a physician champion and oftentimes a nursing champion that concentrates just on one area. So if you allow me, CAUTI is a safety indicator for catheter-associated urinary tract infections. It's an infection. It happens at our hospital oftentimes because we put a Foley in. How do we keep that from becoming an area of infection for us? So we actually chartered a group of physicians and nurses and other professionals along with our quality staff, and they met to talk about what is best practice, what is evidence-based clinical guidelines associated with it, what are the best hospitals. There's hospitals that have 0% infections or very low infection rates. What are they doing that's different? What we found was is that a direct correlation is line days. So what that means is, the longer you have Foley in, the better chance that you're going to get an infection. Not surprising. So how do we address that? We looked at, let's set guidelines around which patients we give a Foley to. Let's look at, we actually printed a report by nursing unit about which patients have a Foley and which ones can we remove. We created a nurse-guided policy that allowed criteria for the nurse to pull the Foley if certain conditions existed. So that decreased our CAUTI rate significantly and allowed us to really increase how we rate and competitively. So it's about creating teams, making your physicians and your nurses champions. It's setting priority around quality, and making it something in which the CEO knows that that is a priority that he or she must make sure to succeed. And look at best practice, look at what evidence-based clinical guidelines is around the care. So to further your question is that yes, those are things in which I think are very important. Our competitors, we need to differentiate ourselves in quality. Right now, our consumers are looking for an easy-to-use option to get care. We did everything from Anywhere Care, which is a computer-based system where you are triaged and you have a nurse practitioner or a physician that actually answers your email and you're on screen and so forth, to urgent care, to workplace care, to any kind of care that would make it easier. Open access models where you don't have to have an appointment, you can come into your primary, much like concierge medicine. We got to change our systems so that we are easier to use. I would also say is that one of the things that we had a problem with in growing was that our operating room was not efficient. So when surgeons couldn't get block time, we had 14 open requests for block time that wasn't satisfied. We've made the process better, and those no longer exist. Secondly is that they couldn't get an add-on case. They have to be at the hospital 8, 9, 10 o'clock at night to add on a case. That's ridiculous. So the easier we make our services to be used by physicians, by the community, by our patients, the more recognized that we will be over our competitors. Make us quality, safe, easy to use, care for the patient and family, I believe, is the ingredients for us to do better than our competitors. And I think the same thing's true for our people side, is that if we can be that kind of organization, people want to work for a winner. I was talking to Troy, and we were talking about how do we have a waiting list for the open positions that we have, and that's by being the employer of choice, being one that is very respectful of their employees, looking at retention rates as being crucial to keeping talented people, looking at what we can do to make employees satisfied. I mean, what we did was that, my gosh, we met with all new employees to see how the experience was and what can we do better. We got to be doing that, and that's being the employer of choice, and that's how you retain staff and you have less of a vacancy rate. And I'd like to think is eventually a waiting list for open positions here.
Thank you. Just one more area, that's all right? All right, just want to drill down a little bit into the finance area. As a CPA, I'm sure you don't mind talking finances. It seems that looking at the numbers, at least that I've seen, that in 2014, the organization in Kentucky was undergoing some financial stress, and those seem to have largely turned around in terms of EBITDA, net income, reduction of overhead costs, bad debt reduction. What steps did you take to achieve those results? And obviously without sacrificing care, how do you, what was your approach there to improve the finances?
Well, I in the interest of time, I could give you the long list of problems that, everything from overstaffing to lack of productivity system to losing market share to revenue cycle problems. I put a list together and it was like 15 items, so I'm not going to bore you with that. Happy to, but I'm sure we don't want to do it here.
Yeah, just an overview is fine for now.
Oh, sure. No, I totally understand. When I came to the organization in October of 2013, the health system was losing more than $100 million a year. It's significant. No organization can withstand that and still be in business. One of the things we did, we got together as a leadership group and made the decision that we were going to reduce our costs by $220 million with goal like that is fine on paper, but it comes down to detail, line by line, to come up with the initiatives to do that. The foundation comment was it doesn't have any impact on patient care. We did not want to do anything that would stunt our growth or growth potential. Didn't want to do anything that would cause any issues with quality, safety, and the patient care, the services that we had. In fact, we had visions of also expanding care in a number of areas. So we put together a list that made up significantly around cost control. We had a GPO, or essentially a buying group, that we weren't complying with. So there were millions of dollars that we could have saved if we were only compliant with our GPO. There were situations, we didn't even have a productivity system when I came in. So we needed a productivity system to see, based upon your job, are you doing it in an efficient way? And if you're not, what can we do to help you to make it efficient? Overstaffing, oh my gosh, there were incredible amounts of staffing that weren't needed for an efficient organization. We needed to become an efficient organization, and then we needed to look at where we place these individuals, and in some situations we had to do a reduction in force, unfortunately. And that wasn't a problem of current leadership, that was a problem of the previous leadership, and we can go into that later on too. So what we did, we were successful in saving about $225 million. We're very pleased with that, with a combination of being, I think, more budgetary focused, being more efficient as an organization, increasing our throughput, and that decreases labor costs. We didn't integrate. We just went ahead and just added layer upon layer upon layer. Our span of control was terrible. So one of the things you saw is that we actually did decrease management positions and support individuals that help those additional management positions. But all that created was inconsistency within our messages across all organization. We looked at, a stable CEO is crucial in that. Revenue cycle was a big issue. We weren't collecting the money that were due to us. That needed to be corrected. So I could go on and on, but we had a specific called out plan of where we were to get each of the savings. We assigned a champion or executive sponsor to each of those initiatives, and we had tactics under each one of those about how to get that, when, and so forth, so that we can show progress. We met on a weekly or bi-weekly basis to actually talk about where we were and any problems or barriers that we needed to overcome.
When you say you saved $225 million, over what period of time are you talking about?
That was over a 2-year period.
Okay. All right,
There's no way, there's just no way you could take that much dollars out of the organization in less than 2 years. At least that's my opinion. You could do it slower, but I really believe that the pace that we used recognized the urgency and the discipline that we needed to have.
Well, even over 2 years, I think that's a pretty healthy number.
That's right.
Thank you, sir.
Thank you.
Thank you, Commissioner Klein.
Thank you, Mr. Chairman.
Stephen, Commissioner Wellen, are you still there? You disappeared.
Yes, I.
Oh, I'm glad that you're back. You're on the hot seat now, so.
Well, one of the beauties of going late in the process is most of the difficult questions have been asked, and I do appreciate your candor. I apologize for not being able to be there, and my intention was to be there. So I look forward to our few minutes we could spend together. So you touched a lot on quality. You touched a lot on, Commissioner Klein asked you a lot about the financials. I believe Commissioner Uri asked you a fair amount about your experience and the different roles. So I want to take you sort of in a different role. Maybe you could sort of briefly walk us through what's a daily routine for you? What are the core things that you try to achieve every single day when you walk in the office? I mean, do you have a set timetable you want to spend, or how do you approach your day-to-day?
I would say is that just as my guess is, if you don't manage your schedule, the schedule manages you. And you know, I have been very fortunate to have some incredible assistants that help me stay organized. But it's based upon, you know, essentially guidelines that, you know, I've set for myself. My responsibility as the leader is to know what's happening in the organization. So some of the things that I have done is that on a weekly basis we have a call with all presidents and all senior leaders to make sure that starting on Monday morning at 10 o'clock, we know what's happening in the organization. Are there any issues that we need to be tackling this week? Is there any follow-ups on important issues? So I would say is that, and if you'll allow me to do it in a week's time frame as opposed to a day, I'd certainly appreciate it. So we have information that we know what's happening to our system in dashboards, and also is that we keep communications open so that the CEO and the senior leadership group knows what's happening, that we might have to take action, or any kind of priorities. Where are we with those priorities? Secondly is that each hospital has on a daily basis a daily huddle. That happens. It's not necessarily my schedule, but the hospital schedule, and that feeds the leadership group Monday morning meeting so that we all stay on top of issues. So first, I would say is that my schedule is around what's a priority based upon the immediate needs of the organization that I get from our daily information, or I guess weekly information look at our organization. So that's really important to know what's happening in the organization. Next, you know, there is a whole host of meetings, and I believe that you know, I meet with my direct reports to ensure that I understand what's going on, understand where they are in progress on action steps, things that they have as priorities for them, making sure that you know, if there's any barriers, anything I can do to help, or that we can work together to get it done. Next is, I would say, you know, from an importance standpoint, is, you know, I love to round. You know, I always think is that the most important part of my job is to know what's happening in our areas that are serving our patients. And so on a weekly basis, I like to routinely round either in a hospital outpatient setting with our physicians, and so we incorporate that as a designated scheduled time. Other than that, it gets lost with all of the things that are going on. I would say next is my management by walking around. Not only is it definitive rounding, but it's also making sure that I know what's going on, even if I don't have a meeting with one of my direct reports. So I think that's very important. The CFO and I have a close relationship, given that, you know, finances is such a crucial part. So I get frequent updates on where we are with the month, especially in volumes, any kinds of issues that have been uncovered, so that we can ensure that I know what's going on. And if it's an issue serious enough, that my obligation is to let the board know where we are, so that I'm totally transparent if there are something that comes up that the board needs to know about. We have a understood rule between the board and myself is that if there is something that comes up, they're not going to hear it in the paper, or they're not going to hear it on the street, they're going to hear it from me. And I think that's only the obligation that I have and the respect that I have for all of you. I would say is that then comes all of the responsibilities that I place on myself, that are action steps that I have, whether that be meetings in the community, meetings with community partners, responsibilities that I have in my role as CEO. So I think that that's an overview of what I would say my responsibilities are as CEO, to know what's going on, to help lead the organization as needed, to ensure that if there is something that is a barrier or an issue that needs to be resolved, my obligation is to make sure that I know about it and I'm helping the leadership team in going about and solving it.
Okay. Okay, so my next question, and sort of along those lines, is you let us know, you kind of answered the question of what you're accountable for. How do you handle staff in terms of, how do they know what's expected of them? How do you give them feedback? You know, what's your evaluation process for not only your direct reports, but how do you account for the diversity of people that work for organizations that are downline that you may not interact with? I mean, what's your process for evaluating that and evaluating the managers that are evaluating them? I think it's important for us to understand how you handle people, you know, as a visionary or leader of an organization.
I think that's very important that you bring that issue up. One of the things that I've done for a number of years is that our organization goes through a yearly evaluation of all employees. Not necessarily just what you would normally see and that we're required by Joint Commission to actually do, and also condition of participation. But we look at every employee, from management staff to staff employee, and assign them, are they a high performer, are they a medium performer, or are they a low performer? And we do this so that we can help the employee. It's not meant to be something that's necessarily derogatory towards the employee. For the high performing employee, it's time for actually us to look at how do we challenge them, maybe even further. Look at them as succession planning for the future. Maybe helping them expand what they're doing and how they're doing it, and being more, we call them re-recruiting them, to make sure that they're happy with what they're doing and how they're doing it, and making sure that we don't lose them to another organization or another organization that wants to give them a promotion. Medium performers, that's really the most of our employees, granted, but they also need to have feedback, not just on their written evaluation, but also is, where are you going? More of a career development discussion. Are you happy with what you're doing? What can we do to make you a high performer? What things can we do to make you a stronger performer? So we work with them, with their immediate supervisor, and also human resources is there to help as well. The low performers, those are the ones that organization has to address. Clearly this is one that's on a performance improvement plan, and we're trying to help resolve the issue so that they can become a medium performer or a high performer eventually. Maybe they're in the wrong place in the organization. Maybe a whole bunch of different things are conflicting here, but we have to address that. So to answer your question, Commissioner, I really feel that it's important for us to do an organizational evaluation of each of our employees, not just the leadership team, because the leadership team goes through that as well, and find that organization, what can we do to help them? How can they be top performers? What can we do to help them from a career development standpoint? We do more for the leaders in that we do 360s. We also used written instruments to help understand them and their leadership, to help them be better leaders. Our responsibility, I believe, is coaching and mentoring our employees. If we don't do that, then we're sentencing them to essentially a career that they may leave. It may not be exciting anymore. I come for the paycheck, not necessarily for really what I went and got educated to do and to get the excitement out of it. I think that's what our responsibility is for a staff employee as well as a management employee.
Okay, so in looking at your resume, I noticed that one of the core competencies that you address is mentoring, which I think is really critical when you're mentoring employees, management, and trying to grow the skill set of individuals as well as promote from within. And we have, a pretty diverse and large workforce. But when you've had a fair amount of movement around in your career, mentoring, how does that mentoring work out? Can you think of a couple of examples where you've come in, where you've had teams in place, where you've mentored them, and those people have succeeded and achieved, big things? I mean, as you've inherited teams at organizations you've walked into, can you think of a couple of examples of where you can say, look, I came in, I had a chief operating officer, I had a senior VP who's now running the big hospital system that I worked with for 2 years and grew them, and what was that experience like?
I would say a couple examples might be at Robert Wood Johnson University Hospital, the CNO was new in her position, and she was an excellent leader, but didn't have the experience in overall operations. I really believe that a CNO needs to understand not just a siloed nursing department, but also essentially all operations, because we can't have one operation's going well and another one that's totally unrelated and they're not talking to each other. So one of the things that we did was got her involved in a number of operating roles in addition to her own, so that she could shadow the lab supervisor, or we put together and kind of developed a listing and plan for her on what she was doing, how she was doing it, what we would expect her to gain from that experience. So that's one example. I think she had a better understanding of the organization, better understanding of how nursing needed to interact with operating departments, especially as we looked at opportunities to decrease length of stay, look at how do we take care of patients better. I would say another example would be, at Catholic Health Initiatives. I promoted an individual that was a more corporate employee to an operations position, primarily in the non-clinical areas, but there were some clinical departments that I gave him in his responsibility. We met weekly. We talked about the role. We talked about his responsibility. I got him to also shadow some of my other vice presidents in operating areas. I had him spend a week in each of his areas to understand what the employees were doing, understand what the role of that department was. So again, we put together, without getting too much detail, we put together a plan for him, and what I did was I coached him through and helped him understand and make decisions for a new responsibility that he had. I think that helped him grow, and I would expect that there may be a future as a COO, maybe even higher in the future.
Okay. Two more areas I just want to ask you some questions about.
Commissioner Whelan, may I please, because of the essence of time, I still have some questions, and is there any way that you could maybe condense the answers as much as you can?
Okay.
Because I don't want to take any time away from the commissioner.
Yes.
But I still got a couple of things and your closing remarks. I know that we
Okay.
started a little bit earlier, and I'm trying to be fair and balanced to everybody. But,
Absolutely.
all right, go ahead. Commissioner Whelan, go ahead.
All right, so let me just touch on this. I have one more question. With respect to sort of crisis management, and obviously we've gone from crisis to crisis in our system through the years. How do you approach a crisis? I mean, walk me through a typical. You walk in Monday morning and you find out something that's really a big issue. What's your instinct to approach it? And then the second part of that is, we've got a communication issue with a number of our constituencies outside the system. We have a fairly large, complex immigrant population. We've got an African American community that feels that they're a little bit underserved, and we also have a large Hispanic community. And how would you address those sort of things where as though they're not part of the process? How do you bring them in, and what would you do if you were here in the first, say, 100 days?
Well, from a condensed answer to the question, crisis will occur. We're a big organization, and it's going to happen. I believe that in those kind of situations, you form the team of individuals that need to be involved in it, whether it's a legal matter, the corporate counsel, board members as needed, operation people. You get the right people at the table, physicians, however the situation in the crisis dictates. And then, it's understanding what the crisis is, getting answers to the questions that you need to know about the crisis so that you can actually make the right decisions. Recognizing that you don't always have all of the answers. What you're doing is, first, you're putting the patients first. The care that you're providing needs to continue, and that the organization still needs to function, even though a crisis has occurred. You make the best decision with the information you have, and in a crisis situation, I've always made sure to ensure that the board members were aware of it. Communications with the community, as I said, I think it's firmly based upon the relationship that you have built with each of the communities that you serve. It is an opportunity for you to listen. It's an opportunity for you to learn. It's an opportunity for you to work with good people of that community to see what we can do to address their concerns. You may not be able to address it totally all at once. You may not necessarily be able to do it emergently, depending upon the situation, but you're staying in touch with that community. You're talking with that community. You're building a confidence level and a trust level between the health system and that community, that you're going to do whatever you can to address the issue and resolve it, because our role is to take care of patients and improve the health of the community.
All right, thank you very much. Chairman, I'll give you the rest of the time. Thank you.
Don't go away.
I'm not going away.
No, we need you.
I'm dead anyway.
Mr. Gilene, you touch up on quality, and you touch up on rounds, which is another question. In culture, I think we've done pretty much we were like the advanced team before our candidates came in, and you have a pretty good team in place here. Just a couple of questions that I share your opinion of how to deal with the media by bringing the good stuff. I am a firm believer that we should be running to the media, not from the media.
That's right.
So
They're a partner. They are indeed a partner.
Yeah, that is
That's right.
correct. And then communication is extremely important because, you know, if you have no communication, it's going to be, no one is interested in some few people interested in the real good things that we do. The drama becomes number one because that's how you sell the papers. And I've learned that from several journals that I know. But anyway, on the taxes, for the last 10 years, we have been through different boards, but I know that since I've been here for the last 4 years, we have been slowly dropping our millage because eventually we would like to do away with the tax burden on the taxpayers.
Yes.
I know the South, our competitors are just, it's very, very little on the millage rate. I forgot what it is, but I just want to know if you share those views too, by making the things that can bring in some dollars, and without calling it profit, but bringing the dollars in some areas and reduce, to provide to those who are most needed. Okay. The question that I have is, shall you be one of the, shall you be the nominee and selected? How long would it take you to have boots on the ground? I'm an all-army guy, so I talk like that. So
I would say is that as soon as you want me to be in the role, I want this position. I'm attracted to it. It's a perfect fit for me. I'd like to start it as soon as you would like me to start.
So you could be here within 30 days?
Yes. Yes, Commissioner.
All right, so unless anybody else has any other question, I'd like for you to go ahead and do your closing remarks, because we have another candidate coming in.
Oh, absolutely.
And I know that.
Okay. All right. Thank you. I appreciate the opportunity that you have given me. I've devoted my career to excelling as a leader and leading health systems. This also includes having both the operational and financial expertise to meet the challenges of today's healthcare environment. These challenges will test the health system, and as a board, it is imperative that you have the best leader, being CEO, in which I believe I am. My focus in my leadership has been to build strong healthcare systems based on the mission defined by the vision that meets the needs of our patients and has the highest quality and that's safe in a patient and family needs, that meets their needs. The Institute of Healthcare Improvement states that we must move to the triple aim. First, to improve the experience of care. Next, to improve the health of our community. And thirdly, is to decrease the cost, and I think that's what you're referring to, the per capita cost of healthcare, without sacrificing quality or patient care. And I think that's really the Institute of Healthcare Improvement certainly is saying what we have to accomplish.
You said it more eloquent than I did, but that's the message.
That's it.
That's the message.
That's what our job is as healthcare leaders. Our focus is, my focus has been to ensure a patient and family focus. This means that we have our patient and families as our focal point. It is a collaborative relationship between the healthcare provider, the patient, and the family. It shows them dignity and respect. It provides information and understanding on the care that is provided and allows them to participate in making the best decision possible for their health care. My focus has been on building strong relationships, and we've talked about how important that is. My focus has been on be a strong communicator. This too is important for our employees and our physicians so that they understand and increase their engagement in the business of healthcare. My focus has been on our talented people, our team, to recruit, retain, and develop our employees. It's crucial that our employees are happy with the employer that they choose and have high engagement or satisfaction in the place of employment. And finally, my focus has been on achieving results. We must achieve results in a fast-paced industry that we find ourselves with many challenges and many changes. We will not be successful unless we have the discipline and the urgency around achieving those goals. I'm so pleased with my accomplishments that I've made in my career, and I believe I can do the very same thing here at Broward Health. You will not find anyone more committed than myself to Broward's mission and vision than myself. No one. I would like to thank each and every one of you for the opportunity to interview for this position. I have the experience, skill, and expertise to lead this health system. I would be a perfect fit for the needs of this system. I ask the opportunity to lead as the CEO. Thank you very much.
Thank you. And you, Mr. Ayamura, he's going now to...
Yes, great job. Losing it, Joe. He's heading over to Broward Health. He's heading over to Broward Health North now. He'll meet with the system leaders there before meeting with the medical staff and getting a tour of the hospital facility. So that's it. Great.
I hope that they're more gentle than we are.
Thank you very much. I appreciate it. Nice meeting all of you.
Thank you. We're going to take just a 2-minute break.
Easy and simple.
Oh, yeah. I was telling you about that. I was telling you about that.
Wonderful. Get lined up here. Completely. Thank you very much.
Broward. The auditorium at the end, one sample. There's a little, small little auditorium right. Just 2 speakers and 2 mics. Not much. Oh, yeah. I saw those other
Time goes fast when you're having fun.
We apologize for being a little behind schedule.
Yes.
When the fun starts.
Not a problem.
Do I have my family here? Everybody's here. Okay. Okay. We never close the meeting, so I don't have to open it. We have good afternoon. No, it's not quite afternoon. Trying to get my bearings here. We have Mr. Robert Minkin. Did I pronounce it right?
Perfect.
Because I'm horrible, with this stuff. So anyway, thank you for being here. I want you to know that you're one of 330 some odd people that turn in the resume and apply in countrywide. We received 10. You were one of the 6 original. 2 left. 1 has got a job. I don't know what happened to the other. That's okay. So I really, you should pat yourself in the back because there was a lot of competition out there. And the vetting company that did, they did a very, very good job as far as I'm concerned in finding us some good candidates. So here's what we're going to do. I'm going to ask you to do opening remarks. I'll ask my colleagues to ask you several questions. And then after that, we may ask you what your vision is. But we're going to make it simple and as painless as possible. So you're on. Before I start, there's Commissioner Gregoire and Commissioner Yuri, Commissioner Klein. And we have Commissioner Wellens up in Colorado in the snow. We have our CFO, Alan, and Goldsmith, and we have Gio Santorio and Peter Ayamora, the head hunter, we call him. Anyway, so HR director, that's easy. So go ahead and try to sell us yourself.
Well, first off, my deepest thanks for having enough confidence in my background to invite me and to participate in this process thus far. I am deeply privileged to be here, feel that. I've done a lot of research in your organization and have felt that you have some immense assets that can provide and continue to provide the community incredible health care. You've also had some challenges, and as all organizations, I think it comes down to how the organization is led. I've spent my entire life in healthcare. I started my first job in healthcare at 14 years old, was washing dishes in a convalescent hospital in Burlingame, California. Quickly grew to the breakfast cook at the adjoining district hospital in Burlingame, California. And I never looked back. I love the culture. I love the caring attitude. I love the moment when a nurse and a physician have a positive impact in the caring of a patient. And that's really what we are here to do, is to improve the health status of our acute patients and indeed extend ourselves outside the 4 walls of our hospitals into our community to affect their health status so ultimately they don't need us. So I come from the left coast, and we have tried some really crazy things Some have worked, some have been pretty crazy. But I've used that experience to help organizations around the country become better. And if you were to typify my career, it was to take organizations from a place that they were not operating well in some cases, or poorly in many cases, to a place of excellence. And so whatever it took, in concert with medical staff leadership and the board, we created a common vision, a plan. Where are we realistically?
Excuse me a minute. Those folks with phones, please put them on silent, or you're going to be fined $10 to your best charity the next time I hear it.
I would take that seriously.
And the pastor is going to collect it all.
Goes into the Sunday box.
And go ahead.
Well said. So I can give you some of the technical stuff in my background. I probably ought to do that for the 2-minute personal commercial. And hopefully that will pique some interest and hopefully some questions in the kind of work that I've done. Currently, I do independent consulting, and what that means is I help hospitals, boards, and CEOs try to figure out incremental problems. And that client base comes from the 5 years pretty much I had served with the Camden Group, and I'll speak to them in a minute. Prior to that, I did international studies. I'm fascinated by healthcare systems. What works, what doesn't work. So I spent some time in Portugal, Spain, and England. And over those 9 months that I was there, I was able to have the opportunity to interview the healthcare ministers from each country and try to understand how those systems are organized against the value proposition, out of the tax base of the country, how much money goes in, and how much actually comes out in terms of true clinical value. There are some parallels, perhaps, to your situation. And it was a fascinating experience and one that I've always wanted to do. And I owe the American College of Healthcare a paper on those findings. But I did that for 9 months. So there was a bit of an interruption in terms of my work experience, and I just wanted to clarify that for you. Prior to that, I ran the market, South Bay of San Francisco market for Verity Healthcare. Verity Healthcare is a new not-for-profit healthcare management company funded by, formerly, a private equity firm out of New York. This was a 6-hospital system based in California, San Francisco, 3 hospitals, Los Angeles, 2 hospitals, and a nursing home. They were a day away from bankruptcy, and I have it deep in my heart to help save hospitals that are safety net, and that's what these hospitals served as. They had gone through 2 prior failed sales with prior other Catholic organizations, and it just did not work out for various reasons. Verity came along as a not-for-profit healthcare management company hired by the private equity firm to manage these hospitals. And in a very short period of time, we were able to do some very significant things to improve the organization's financial standings, not to the place where the PE firm wanted to be, but in my mind, we did some really good work. Reinstalled boards, reinstalled the confidence of the community and the medical staff, and were able to begin to keep away at the $110 million loss that health system was seeing. For my region, we were successful in reducing the loss from $35 million on par to almost break even by the time I departed. Prior to that, I served as a senior vice president for the Camden Group. That role was to advise hospitals, health systems, medical groups, and insurance companies how to do payment reform. And I leveraged some experience and some unique experience in Denver, which I'll describe in a minute, as well as help that consulting firm start a hospital operations consulting practice. It did not have it. They were primarily strategy planning. They did facility planning and service lines for the most part, and you have many. I brought to them an understanding how to create a payment reform practice, how to teach hospitals and in healthcare how to move from fee-for-service to value, and leveraging the experience of being one of 4 hospitals in the nation to actually demonstrate bundled payments in both orthopedics and cardiology. So that was a 1-year job that turned into 5 years. I had no clue that I actually stayed there that long, but we just kept having fun, and the demand for the services continued to grow. Prior to that, I served as the campus administrator for St. Joseph Hospital, which is with the Sisters of St. Joseph of Orange, now with Providence Healthcare. So if you look to the West Coast again, the primary Catholic systems, Providence and now St. Joseph, come together, and as you may be aware, they're discussing joining Ascension to make the largest Catholic system in the country. That was a turnaround. When I joined, they were losing about $20 million a year. When I left 8 years later, they were the first magnet hospital in the state of California, Catholic hospital, that was awarded magnet status. We were the quality leader and the profitability leader in our 14 hospital system. Prior to that, I served at Exempla St. Joseph Hospital, or I kind of jumped over that one, in Denver, Colorado, a 550-bed Catholic teaching facility operated by the Sisters of Charity of Leavenworth, the largest hospital in this and the oldest hospital in Denver. Also a unique relationship with Kaiser Permanente. You may not see much of them out here on the East Coast. I think they have presence in submarkets, but on the left coast, they are the dominant HMO and certainly largest in the country, with almost 6.5 million members. They are a staff model HMO. In Denver, for the most part, they did not own or operate their own hospitals, which is atypical to their modus operandi. And we had a long-standing relationship with them, and they accounted for about 80% of the hospital's business, the other 20% being safety net patient populations. The hospital was 110 years old, and it was literally falling down around our patients. And the strategic challenge that I had to undertake was to diversify the portfolio from a payer standpoint. I think one of the hardest things for hospitals to do is to actually be of greater value to other payers beyond those you have today. And to do so, we participated in the nation's first bundled payment demonstration of any real scale. It happened once in the early 90s in Atlanta, but we participated in the cardiovascular demonstration that started to teach hospitals and doctors how to move from fee-for-service into a fixed payment arrangement that wasn't capitation. And how do we create better clinical quality? How do we create better economy? And as a result, how do we offer better value to the market and to the patients we serve? We were very successful in that undertaking and grew market share substantially, as well as you can tell, served to be part of the database that justified CMS rolling out bundle payments now nationally, and that juggernaut will likely continue into many clinical areas. I served as president and CEO at Desert Hospital Corporation of Palm Springs, a district hospital. Operates much as you do, single facility, but we did operate significant numbers of ambulatory sites. Last one I'll highlight is the Hunter Group. For those that have been in healthcare a long time, that name kind of makes you take notice, because we would be called by bondholders or health system executives, go into hospitals that, for example, have issued paychecks they couldn't cover the next day, and they'd call us in to go fix it. So we went into some very dire circumstances, and the role there in 6 weeks was to assess the hospital, understand its possibilities, find a way to partner it off, improve its economy, and help make recommendations to governance in a very short period of time so they could begin to save the organization. So the theme of my career has been transformation. I can go deeper into the career if you have questions, but I think it kind of tells my story. That I've spent lots of time understanding organizations, what's their strengths and weaknesses, looking at management teams and finding strengths and gaps, promoting people in the organization that have a desire to grow, building world-class teams that accomplish world-class results. I am towards the end of my career. I have a desire to work another 7 to 10 years. I do have children that would be based in California, but getting on a plane and going back and seeing them once in a while is not a problem. And thank God for FaceTime. So with that, I'm happy to answer any questions you might have.
Thank you. Commissioner Gregory.
Yes, at the Hunter Group, you made a $16 million change in just 1 year's period, it looks like from your resume.
Yes.
Was there one major focus that caused that incredible shift over a year?
It's often many things. So if you think about an organization's use of resources or where its revenues are derived, do we have enough volume in the organization? Is the quality of our revenues consistent with market payment? Are we efficient in collecting our bills? So is our revenue cycle working efficiently? Are we managing our labor expense, our single largest expense in all hospitals, efficiently? Is it going up with acuity, going down with decreases in acuity? Same thing with volume. So are we flexing to match revenues to expenses? Are we using consultants efficiently, or hopefully not very much? Are we efficiently and collaborating around our supply chain and minimizing as much diversity as possible? Is our clinical quality meeting expectations such that we are not deferring business or patients going to other places because we are not meeting quality scores? So is it one thing? Generally, no. Now, first place in an extreme turnaround like at the Hunter Group, we would look at labor. Then we'd look at non-labor. Is the quickest thing we could do to moderate and close the gap on the losses that these hospitals were seeing. But that's always a short-term approach. We have to address revenues and we have to address quality in order to give the organization a sustainable approach to the market.
Thank you. Second question. When you were at Desert Hospital, you resolved a long-standing conflict between the board and the medical staff. Could you explain what the conflict was?
Yes, we had two physicians who served as fiduciaries to the Not-for-Profit Management Corporation. Now, in that district hospital setting, the district leased the assets to a not-for-profit organization that had the management contract to run the hospital. Another weird arrangement. The board chair of the not-for-profit corporation became in deep conflict with two of the physicians that were serving on that board. They went through a strategic planning process. The corporation decided to advance itself into ambulatory care, create a surgery center, imaging, cancer center, those sorts of things. The physicians liked the idea so much they decided to do it directly across the street from a hospital. So, the story gets better.
What else is new?
The story gets better. So the two physicians were excused from the board and lawsuits started flying, as you can imagine. The result was the physicians in the community aligned behind the two physicians and boycotted the hospital. And the census went from 280 in one day to 40. And that
How did you resolve it?
There were significant changes in board leadership as well as in administration. And the lesson learned there is when you lose, don't lose the lesson. And the lesson is work well with your doctors because they control your revenues.
My third question is, as far as community involvement goes, you have to work well with doctors and staff and patients and all, but for me at least, our community reputation and interrelationship is very, very important. Sitting behind you, I've introduced them to each candidate. These are the leaders of our African American community, but we have many minority communities, and they are a large part of our patient base. How do you work with the communities? How do you find out what their needs are?
Well, first, you do a community needs assessment. I've gone through yours, but those things have, frankly, very limited utility. They help you with the IRS and compliance and those sorts of things. Much of the CEO's role in an organization as this is being outwardly focused, is understanding the needs of the community segment by segment. So in almost every one of my experiences as a leader, I have tried to find ways to properly integrate myself personally and my team into the segments of the community that we serve. We're volunteering, we're serving on boards, we're attending events, we are visible. We have to be seen as assets that they can find and are accessible so that they can help us understand their needs. So I think accessibility, transparency, and visibility is critical in roles as this one.
And then my last question is, how do you work with the press?
Carefully.
That's always good, but beyond carefully.
Maybe that's my
accessible. Obviously, your CEO is intended to be the face of the organization in many ways, and it's important to be open, communicative, and understanding of the press's need and right to understand what's happening in the organization in the proper way. So I've gone through all sorts of media training and been on television and all sorts of different things, so that's not a challenge necessarily for me. Actually enjoy it.
Thank you.
Thank you. Commissioner Uri.
Awesome, thank you, welcome. Commend you for being the first person from the left coast to admit you actually come up with some crazy ideas. At least the first person I met. Public tax supported system, obviously. Certainly our focus is to remain that way. But what do you see in terms of the not-for-profit, for-profit, but focusing obviously on the not-for-profit, virtues and challenges of that structure?
So we have a mission. Our mission is to provide the kinds of care that you are providing today and perhaps beyond. The payment systems may have an influence in how you implement that mission. So one of the things you'll see spotted through my background is various developed relationships with external organizations to help accomplish a common mission. Because of who and what you are and your scale, I don't ever see you changing much of how you are owned. Are there opportunities to do partnerships? Yes. Are there opportunities to extend ourselves in a way that we haven't before? Certainly. So if your question is directed as to how would we extend the mission of this organization in concert with others, partnerships are exactly where healthcare has been going and is going, and you already have some of those from those that I've been able to research. So did that answer your question, sir?
Well, I guess I'm a little bit more focused on what you see as some of the challenges. This is a perfect example of one. Okay. Obviously, transparency and engaging with the public is paramount, but it presents challenges when it comes to strategic decisions, financing alternatives. Our shareholders are essentially the community, taxpayers. Okay, so we answer to a different, different constituency, and in so doing, profits over population health. It's a different debate here, right? We're not focused on profits. What we're focused on is, are we utilizing the resources that the community gives us, the assets that this community has built over many, many years to serve them in the best capacity that we can. And I'll just leave it at, in terms of my focus is, we send a lot of money to Washington, D.C., a lot of money flows into Tallahassee, and how is the decision-making process focused to utilize those resources for the needs of the community?
So, where do you want to be in 5 years? What's the future state of the organization from where we sit today? And that's a vision that I think everyone in the room has to help co-create. So, first understanding what that endpoint looks like. What's the payment system going to do in terms of how resources are generated? What's the value proposition that we're called to create more so than we do today? It's kind of a philosophic, but it's a very pragmatic question as well. Because if reimbursements in healthcare continue to wane, which I think they will, and organizations as this will be called to produce greater value, we're going to be asked to make tough decisions about what we do and what we can't do. So, the way that you do your accounting, for example, you have a huge organization of acute, primary care, ambulatory care, and a lot of community services that do outreach. Some of those lose lots of money. Do we understand that clearly enough, and are we able as a governance group, as well as management, to be able to work with the community to understand what's the most valuable of those services? And what perhaps should we not be doing? We use 100% of our tax revenues to support 100% of our operating loss here. And I would wonder, at what point do you want to start thinking about reserving some of the tax revenues to do other things? Or to give it back to the tax base, which I think is the highest and best of what the commission's supposed to be doing.
We're at that point.
Yes. So at some point, we're going to be talking about what's adding value and what's not. What can we afford to do and what's optional? And in a public setting, it's always difficult to make those decisions, but you have to do it in a public setting. There's got to be a give and take, an exchange from those that we serve. But you get the big bucks, and you have to make the tough decision with the recommendations from the CEO. So at some point, you'll be faced with those decisions if you're not already. I hope that was helpful.
Except I don't get the big bucks. You had indicated that in your opening statement, you see 7 to 10 years of in terms of your
Remaining
career. Okay, not many organizations, and if I've misread some of the days, not many organizations have you spent that amount of time at. Okay, we can all debate whether 7 to 10 years is sufficient or not. I personally wouldn't say that it's, of course, sufficient, but implementing from a CEO role a vision that is certainly something that has a horizon that's more than a few years down the line. Otherwise, I wouldn't call it much of a vision. But can you elaborate, I guess, on some of the different roles and the timing in which you've done it in terms of your career, and how we could have that confidence, I guess, that you're committed to this organization?
Excellent question. I think you understand as well as anyone in the world, and certainly in the country, that healthcare is volatile. And change is happening at the fastest pace ever. So when a friend of mine calls me and says, we're about to save 6 Catholic hospitals, are about to fail, would you like to come help? That pulls at my heartstrings. But what I would say I underappreciated about working with a PE firm is what their real driver is. I knew it, but I didn't really know it. And it became very clear after 14 months, and 4 different bosses in that 14 months, that the volatility there was not going to lead to being able to be successful from my perspective. So I went to my 4th boss and said, this isn't working. I think it's better that perhaps we part ways. So I wasn't willing to go through the tumultuous change that they were experiencing at the corporate level in order to be able to continue to deliver the kinds of results the financing organization we were working with was expecting. So that was a very personal decision. It's probably the most intense job I've ever had in my life. Camden Group, 5 years. As I said earlier in my opening comments, I intended to go there for a year or 2, and that was it. But the we were in the right niche at the right time, and frankly, I was having a great time doing that, flying all over the country, including coming down here, helping organizations learn. And I had a really good time. It was fun. In Denver, I was there 4 years. That situation was an amalgamation of 3 hospitals between various owners. And given the circumstance of the ownership, in order to create a new hospital that resulted in $600 million of incremental debt by the owner, they were unwilling to continue the management company relationship that they had. I'm very proud of the work I did there, because if you go to Denver today, you're in Denver, the new St. Joseph Hospital downtown is on land that I was able to acquire and get them ready, not only from a physicality perspective, but also from a financial perspective, to be able to afford being able to make that investment and take on that debt. Those are big, big changes. But once ownership changes, the first thing that typically happens is management changes. And I've accepted that. That just comes part and parcel with leading healthcare organizations out in the private sector. So, did I want to leave Denver? No, I didn't. I really wanted to stay. I wanted to see that project through to positive completion. But the new health system leadership decided to sweep all the CEOs, not just myself, as well as all the folks in the health system. So, I would tell you that I'm not itinerant. I do intend to be deep part of the community I serve. I want to live here. I want to be visible. I want to be seen as making a positive contribution. And that's one of the reasons I'm here talking with you today, is I see that to be possible more here than in other circumstances that may be available around the country.
Gotcha. My, I guess, last sort of comment, but to the extent you have a reaction, I'd be interested in it. The likelihood is that the folks sitting here today interviewing you and evaluating whoever it is that ends up being the CEO of this organization, the likelihood is most, if not all of us, won't be here through that
Indeed.
vision, okay?
Indeed.
And so, understanding that, what reservations does that type of, and this I guess sort of goes back to what I was getting at with how we're structured, publicly. And I guess I'll be a little bit more forthcoming, and I ask this because these would be the things that I would be concerned about if I was in your seat.
I think changes in the personality of governance happen on a fairly responsible basis. If I understand how you replace yourselves,
We don't replace ourselves.
Well, I understand the governor appoints you, but it's on a point where not all of you go at the same time. It's on some kind of rotational basis. Am I correct about that?
Well, it all depends.
That's the intention.
There's folks that have served here for 20 years and chair the board for 20 years, and there's folks that have served for 2 years, and there's folks that just say no mas, so we're all ending at different times. Some sooner than others, but go ahead.
Thank you. So I'm less concerned about that. I recognize that that's a potential risk here, and thus the need to be as transparent about what the health system is attempting to accomplish, so that anyone who chooses to serve in the capacities you serve today will understand the direction the organization's intending to go, and will, of course, have an opinion about that. And hopefully their guidance will be helpful to make that vision more effective. I can only hope that's their intention. And if for some reason a change in direction as comes to us from governance is indicated, we would make that change.
Well, guess the one constant is the community. So hopefully our vision is consistent with what the community wants. And if that's the case, everything else should fall in line. So anyway, thank you. Go ahead.
All right, Commissioner.
Thank you, Mr. Chairman. Thank you, Mr. Minkin, for joining us today. One of the first things I wanted to ask you about, there's a bullet point on your resume indicating that you were rebuilding the governance structures consistent with the Attorney General's conditions of operation. Could you elaborate on what that entailed?
Yes. In the state of California, in many states, when not-for-profit assets are sold to a new owner, the state attorney generals have to approve the transaction. And inherent in that transaction are often conditions of how the organization is intended to be operated going forward. So, in the context of 6 prior Catholic hospitals that were largely safety net hospitals in their community, if it was operated as many for-profits operate, the majority of the patient base served wouldn't be able to access the hospital any longer. So typically the Attorney General will elicit conditions. Have to honor certain union contracts. I know you don't have unions here. You have to maintain the same level or greater levels of charity care. You have to continue to support certain local sets of vendors, those kinds of things. So those would be the conditions. When it came to governance development, there was a proscribed membership of local hospital board composition that we had to create. So representative from the Latino community, representative from the Asian community. So there were very demographically based requirements.
And that was an advisory type board?
Yes, there were reserve powers held by the corporate board, but they were serving as the hospital board. They approved medical staff actions, they approved budgets, then sent them up to the corporate board and the like, which was pretty typical.
So how would that be analogous to the way this system operates here in terms of the board or the corporate integrity agreement that we're currently operating under?
There are conditions that you have to operate under that are unique to you because of some of the things that have happened here in the past. So obviously we have to be completely mindful of that and how we operate and how we govern and how we manage. So there are some parallels in that regard, not promulgated from different places. Nothing of that organization was public. Everything was behind closed doors because it was a private company. So we're held to a much higher standard here. And that standard is not only to report out on our actions around compliance to those conditions and show publicly how, and reporting to the feds exactly what those conditions and effects of those conditions are.
You have an extensive level of experience, a lot of diversity of experience, not all as a CEO, a lot of it as a consultant, as a fixer. Could you encapsulate the applicability of your experience as you see it to this role as the CEO of Broward Health?
So, understanding strategy. Your CEO, I think, first and foremost, needs to have an understanding of how to evaluate a market, understand the needs of the communities we serve, understand the unique elements of community health that are not being well served, and that's particularly one of the things that's unique to your mission. And to be able to organize an approach to meet those needs within the resources that are available. So my experience as a consultant made me a better CEO. My experience as a CEO made me a better consultant because I could sit with a C-suite and relate very clearly to their needs, what they're facing, and be able to quickly get to the kinds of solutions that would meet their needs. Leading as a CEO is much the same thing. A lot of it has to do with how much data you can gather interpersonally from sources that help us understand who and where we are and where we need to go. So a lot of my experience is based on trying to make the organization better. And as we were talking earlier about, are our volumes where they need to be? Is the quality of our revenue where it should be? Are we collecting our funds efficiently, and are we not leaking? All the operating elements of the organization, I'm very skilled, I believe, in being able to assess and be able to find those nuggets of where new opportunity may lie so that we can better fund the organization at the bottom line. One of the things you'll find me pushing very hard on is the development of the value proposition. And I think healthcare is called to show, for the immense amount of resources that we receive, how effectively we're using them. So whether it's treating a Medicare patient or a Medicaid patient or a commercial patient or one without any resources at all, are we doing it efficiently? Are we doing it consistently across the system? Are we treating patients to the best demonstrated practice that's available in healthcare? So we have one standard across the system, which helps us then get to higher levels of reliability. So when we think about how others would view us, if our reliability is improved, if our quality is improved, and our economy is improved, I do believe we're going to be meeting the mission of the organization more effectively.
Now, at one level, you identify the deficiencies or areas for improvement or things that are being done well that can be improved upon. Then there's the implementation aspect, how you get buy-in from the organization, how you implement that on a day-to-day basis. You're coming into a large organization. There may be resistance to some of that change. How do you implement that vision and those principles without causing departures of key personnel or significant numbers of personnel at any level?
So a common vision is important. Who are we, where are we, and where are we going? What are our opportunities to improve? What are we doing well, and what can we replicate in the rest of the organization? So none of what I've done in my career is anything other than been facilitated by developing the most effective teams possible, in concert with our physicians and other caregivers. So one of the things your CEO has to be is visible about what we do well and where we need to improve, and be able to create consensus about that moment in time, and to engage the organization to help create those solutions. So the turnaround at St. Joe's in Orange took 6 months just to evaluate, and we needed a huge culture change. They were staid, very slow, the typical old Catholic hospital that employed people as part of their mission rather than thinking about using resources to actually execute their mission. And we created multifunctional teams that over a period of 3 months evaluated options to reduce their operating costs by as much as 30%. And they would present as a team those ideas to a group, governance, medical staff leadership, sponsorship, the like. And that group then approved some of those ideas, resulting in collaboration across the organization on how we were going to create greater economy. There was huge alignment to achieving those goals. So a lot of it is crafting a process that engages people to participate. You are not in a crisis situation from everything I can externally understand. So if you're trying to get to greater levels of economy, for example, we have time to do it in an intelligent way that addresses the current culture and the future state of the culture you would like to have in the organization. Senior leadership needs to align around that process. And I'm particularly passionate about making sure that there is in the room all the possible debate there possibly can be. But once we get out of the room, we are one. So you will find me to be a very listening-oriented leader that seeks everyone's opinion and tries to mold those opinions into a process that will move the organization forward.
That's helpful, thank you. Let me ask you, you referenced your experience at St. Joe's as president and CEO. One of the items on your resume is you indicated you achieved 17% EBITDA and 6% income. Could you expand upon those performance results?
Sure.
What those mean? Over what period of time we're talking about?
So St. Joe's in Denver is what you're referencing,
Yes.
is that correct? Yes. So when I started there, as I said, we had a primary relationship with Kaiser Permanente. So our EBITDA was about $20 to $30 million south of that, and our income from operations was 0.1%. And that was a result of Kaiser reimbursing us at basically cost plus 1%. So it didn't fund capital, didn't fund depreciation, didn't fund anything other than they just kind of used us as an operating entity and kind of paid like you go through a drive-through. In order to meet the strategic needs of the organization, as I said earlier, I had to expand relationships with other payers while not dissatisfying Kaiser. Use bundled payment as a tactic to do that, not only with Medicare, but with commercial payers, United in particular, and created a unique relationship with them where they preferred our organization for cardiac surgery, doubling our cardiac cases. And the result of that effort, by almost doubling our Medicare business and adding about 250 United cases where we were their prime vendor for all of Denver for a period of time for cardiac surgery, resulted in an increase in those results.
And over what period of time are those results representative?
Almost 4 years.
Because that's from start to finish over that 4-year period.
That's right.
Okay.
That's right.
And in terms of quality and finance, those two areas can be at odds, or can be complementary. How do you view those in terms of refining the financial structure, the performance, as well as improving the quality care at the same time?
My experience with value development may modify your contention. I think better economy results in better quality, almost universally. I think the inside baseball methodology by which you get there is by removing unjustified variations in clinical care. Do we do a hip the same way? Is the workup the same? Is the implant the same? Is the amount of time patients spend in recovery the same? Are the drugs used the same? So if you can get 5 different orthopedic physicians to sit in a room and describe their clinical process, I guarantee you that very few of them mirror each other. So if you were to align those processes to best practice, I guarantee you that, certainly in my experience and in my consulting practices, that's what we were teaching everyone how to do, is how do you bring the docs together to get to a point of aligning around best clinical practice. That way we get to one implant. That way we get to a standard approach. That way we get to clinical reliability. Quality improves, satisfaction improves, economy is very predictable.
Now, what about in terms of infection prevention, reduction of numbers, as well as wait times and repeat readmissions? Could you address those? What's your approach to addressing those, improving those areas?
So first off, are the resources in the organization sufficient to create those kinds of results? Also, the support systems in the hospitals, are the hospitalists attending to those situations correctly? Or do we allow community physicians to roll in and roll out and not pay attention to those kinds of conditions in their patients? So some of the more touchy parts of clinical practice are what are the rules of engagement around how patient management occurs within each one of our hospitals? And I don't have enough information about how you operate today to give you a better answer, but normally I would seek to find ways to improve collaboration between the hospitalists, if you have them, I think you do, and those that are admitting patients, so that we can follow a tighter clinical protocol, and that we're monitoring patients more real time, so that epidemiology or other subspecialties are called in at the time that they're needed. So the science is there. It's all about how you deploy it. you have an EMR that will allow you to do those things. And one question I always ask is, are you maximizing the use of your information technology tools around how you do patient management? And I don't know that answer yet.
All right, thank you, sir.
You bet.
Commissioner Whelan, thank you for your patience.
No worries. Thank you. I just lost your picture, but I'm sure you're still there. I have a couple of questions, and you may have answered them before, but have you ever operated under a corporate integrity agreement in the past?
With CMS, we did have a conditions of participation restriction at St. Joe's in Denver before the hospital was replaced. But that is the only federal agency I believe I've had to manage unique relationships with in my career. All the others were not, other than with the state attorney general at Verity. Those would be the only two that I could think of that had unique operating requirements outside the norm.
Have you reviewed Broward Health's corporate integrity agreement and the rules of the role that we're required to operate under at this period of time?
I honestly have not. I looked for it and could not find it.
Okay. You know, we have some challenges. Certainly, compliance is one. Meeting, you know, the objectives of the corporate integrity agreement and fulfilling those obligations are mandated upon us to oversee and for the CEO to implement and to continue to monitor. So those would be issues that would, you know, that would be important. That you understood what the needs were and you felt comfortable that you were, it was an environment in which you could succeed in moving this organization forward. So I was certainly hope that that's something you could take a look at. I want to ask you a couple of questions. In St. Joseph's Hospital in Orange County, you grew net revenues by 40% to over $520 million over that tenure. Can you point to a couple of areas where you were able to come in and work with the existing staff and really sort of grow that? And what did you do? And what were some of the successes that you had there? I think that was a big growth over a short period of time.
I would point to two primary areas of development. The craziness of managed care development within California, and certainly Southern California. We were described once as the crash test dummies of managed care, and I have scars to prove it. We jumped into capitation both feet, and that was one reason why our net revenues grew. Another is we established much more intentional clinical service lines: orthopedics, cardiology, ENT. We created a very large cancer center from nothing, and the development of those service lines rapidly grew market share. We did so in joint venture with third parties and physicians in the community in order to fuel the growth. And when you look at the 8 years that I was there, those were, I think, the primary reasons why our growth was so substantial.
Have you, and it's not clear in the resume, but have you had experience in working with a special taxing district where you've got ultimate responsibility for significant amount of tax revenue and a hands-on responsibility there? And were you able to maintain those levels of taxation, or did they grow over time? If you have to share that?
Yes, at Desert Hospital in Palm Springs, it was a healthcare district, as is yours. I reported to the healthcare district board. They maintained responsibility for the mill rate, and we were managing the facilities that we offered with using the tax revenues that were there. Over the 8 years that I was there, I believe the mill rate actually decreased as the hospital's performance increased.
Okay. Last thing is, have you, and maybe you shared this earlier, can you talk about your approach to the outside community or different constituencies and how you might approach different communities that are concerned, immigrants, African American, Hispanic, we serve all those communities, and what would you do there to sort of alleviate some of the concerns they have? How would you approach that?
As I said earlier when I was asked a similar question, I think it's part of the senior leadership's role and responsibility to be completely transparent, completely available, and completely participative with those kinds of organizations and those kinds of groups. So one of the management sets of goals that senior team and hospital leadership will typically have will be to identify those key groups and to be able to assign one of us to be their liaison. I personally try to be as visible with those groups as I possibly can be. There's also a process that many organizations, as you are structured, where they do a community assessment that's very different than the community health assessment that you do, where it's actually 3 days of the community coming in and talking to us about what we're doing well and what we need to improve as we are developing our strategic plan for the year. So those would be the kinds of tactics that at least would make some sense to start out with here.
Have you had any experiences in any of these communities where you've been CEO, where you've had sort of an adversarial relationship that you've been able to turn around and turn into a real positive?
Yeah, at St. Joe's in Orange, we served the adjacent Latino community, very indigent, highly uninsured, huge users of our services. And we created, along with some of the sisters, an outreach to that community who felt as though we were ignoring them. We were able to qualify for a Robert Wood Johnson Foundation grant, and were able to buy 4 mobile vans and create an outreach to that community where we went to them using mobile vans, one for podiatry, one for dentistry, one for primary care, and one for diagnostics. And we would park in parking lots at the El Pollo Loco and in other community locations that were convenient for them. And over about 3 years, it went from you're ignoring us and we're not happy with you to a very close and tight-knit relationship.
Okay. And last question is, one thing I didn't see in here is well, maybe it's sort of covered, but what's your philosophy on mentoring executives, growing them? Can you point to a couple examples where you've had executives work with you for periods of time where they're now running big organizations and you feel like you've had a responsibility in getting them to that level?
Very much so. Thanks for the question. One of the highest and best things you could ask of your CEO is to mentor the next leader in concert with the view of the board. And so, again, developing tight teams, developing the right people in the right roles is really the modus operandi for any system CEO to be successful. At Verity and O'Connor, I was able to hire someone from the outside in this case because the position didn't exist. But I did promote the CNO to COO and was able to grow her into that role that she serves in today. Before that, she served as an assistant in the nursing department. At Desert Hospital in Palm Springs, the COO followed me as the CEO, served in that role for another 2 years until she decided to go off to another kind of healthcare organization. So I do have a history of helping to mentor those in the organization that can replace others or myself.
Okay, that's great. Last question. What do you think your greatest achievement has been in your business career?
I really look back at the 4 years I spent at Exempla St. Joseph in Denver, and the ability to do very big things in a very short period of time, resulting in the development of a brand new hospital, a sustaining presence in that market, I think was one of the bigger things that I was able to accomplish. I think all of them have their own unique positive, but I think when I look back, that's probably one of the things I'm most proud of.
How about anything a decision you made it turned out to be the right one, but you learned from, and you never made that mistake again in the future?
Yeah, good one. Over the years, I tend to not listen to the gut when it tells me I have the wrong person in the job. I keep trying to get them successful, but I keep hanging on. I've learned that sometimes it's always good to help them move to their next opportunity when we're certain they're not capable of being successful in that role. Hopefully that's not the case many times, but I've encountered that from time to time, and it's kind of in my DNA now about wanting to make sure that if it's just not the right person, it's time to make a change. The strategic failure that I most regret is at Exempla St. Joe's in Denver. We started an orthopedic hospital as the health system started it before I got there, a venture to create a freestanding orthopedic hospital adjacent to St. Joseph. From day one, my gut was telling me this was not going to go well. I tried my level best to make it successful. I served on the board, but they had appointed a management team and had a creation with a relationship with a management company that just wasn't, in my opinion, implementing the organization correctly. 3 weeks after they opened, an untrained 2-year nurse administered 10 times the pain medication to a patient, a 32-year-old woman, and that patient passed. When I look back at my career and I connect the dots about decisions and how it has impacts on patients, I can't think of one where I could have acted more differently a whole lot faster. So I regret what happened there, and I believe that an actual patient paid the ultimate price for something that maybe I could have, along with many others, but I could have intervened at and had a different result. So I know very personally that the decisions we make as healthcare leaders have a direct impact on patient care, and I feel that and know that every day.
No, I appreciate that candor, and it's a tough question to ask, and I think, humility and humbleness and honesty is important as a CEO and as a visionary for the organization, because you're going to lead, not for us, we're 5 or 6 people, but you've got 10,000 employees and hundreds of thousands of patients that will rely on your long-term decisions. So I appreciate your candor there, and I appreciate your honesty. And one of the advantages to going last is I have smart people in front of me. Ask a lot of questions I had, so I'll turn it over to the chairman. Thank you.
Thank you, sir.
Don't go away, Commissioner Williams.
I go nowhere. Okay. You dismiss me.
Mr. Minkin, just briefly, just a couple of questions that I want to go over with you, because my colleagues kind of did around the world in 80 days or whatever the deal is. How often would you round?
Virtually at least 2 or 3 times a week on all shifts.
Okay. You mentioned, we talked about you came from the left coast, and our goal for the last several years, 10 years at least, have our opinion for, has been to continue to reduce the burden on the taxpayers, and without diminishing the work that we do on behalf of those less fortunate. So actually, it's just like when we look at the South Hospital District, which is it's hardly any millage, and we have been able to drop maybe 5, 3, 10 million every year to accomplish that goal. So are we on the same page if we continue to do that to avoid the burden on the taxpayers?
Indeed. I think that's the highest and best that we as a group can do for the community we serve. That being said, there is a balance there.
Yeah, I understand.
And I think one of the things I hope that your accounting systems provide is for all of the things that are not core to you, what do they cost and what are the benefits? And I hope that's transparent and visible for you and the community, so that you can all of us are aware of how those resources are being used and be in a position to make an intelligent decision if you'd like to make a change.
The reason I say it because traditionally it's been the goal of this committee to eventually do away without taxpayers' burden.
Okay.
Should you be chosen, okay, how long would it take you to have boots on the ground?
Physically here,
Yeah,
30 days.
that's good. And you also share my concerns. I heard you talk about the media, that by bringing the good things that we do, be proactive, be progressive, we should be running to the media and not from the media.
Indeed, indeed. And you have so many good stories. And I'm anxious to understand how you do that today. I've done some research on that over the last year or so, but it's been overshadowed by some of the difficulties you've been facing.
See, I learned long ago that when you're right, no one remembers, and when they think you're right, no one forgets. So,
Indeed.
would you like to now entertain and give us your closing remarks?
So thank you so much again for the invitation to be here. It's a real privilege, and I am humbled to have been selected as one of your 4 finalists. I'm an enthusiastic person with boundless energy, and I love healthcare and I love making it better. In my DNA is being transparent. What you see is what you get. And anyone you would talk to about me, I think you would get the same impression. I'm anxious to learn more about your organization and what your needs are. I'm anxious to help make the organization better. And that's how I see myself, is by trying to do everything possible to take the raw materials you have in this organization and to continue to deliver on the value promise that the public expects us to deliver. And that would drive me in the role here. So again, my deepest thanks for your invitation. I'm anxious to learn more, and I'm anxious to serve if you would so choose. Thank you, sir.
Well, thank you very much, sir.
Thank you, commissioners.
Commissioner Wellens, hold on for a second while we say goodbye to Mr. Minkin. Mr. Aguilar, you're going to take him now to see the doctor, right?
Absolutely.
Okay.
He will be going to Broward Health North to meet actually first with the leadership teams and then with the medical staff leadership. So, and then you'll take a tour of Broward Health North. So we're excited. Thank you.
I hope you feed him over there.
Yes.
Yes, thank you, sir.
Hey, thank you. Thank you.
Thank you very much for coming to see us.
All right, Commissioner Wellens.
As promised.
Where are you? Get him back. Commissioner Wellens.
We do a virtual handshake.
He's doing the virtual handshake. Oh, I'm glad you're back.
Sorry about that.
All right, let me go over this with you, okay? And
Can somebody turn that camera around so I can see you?
oh, I'm glad you're back. Anyway, as you recall, although this is a special board meeting, you and I were charged with the process and protocols of this interview process since way back in, I think, March. And I guess we started in March, and then we made, we went through the posting, and we have, to my thinking, we have 4 well-qualified candidates. And by next Wednesday when we meet, we should be able to come to a consensus and appoint one of these 4 in order to fulfill the commitment that we made to this community back in May. So, having said that, I believe that the last time when we elected Dr. Osanari, we chose 2 people. In the event that there were some issues with the contract or what have you, I know that they still have to go through the medical team, and they'll come back with a recommendation, okay? It's not a binding recommendation, but it's a recommendation to help us. And they'll be bringing that on next Wednesday, correct?
That is correct.
Okay. Also, the leadership team will bring in their recommendation next Wednesday.
That is correct.
So what I am going to ask of our fellow commissioners here is to keep 2 people in mind from this meeting, from the 4 that applied and spent like almost a year. They have a lot of perseverance, this guy, because hanging in there for almost a year to just be interviewed by us is a daunting task. So I believe that I'm going to ask them to keep in mind 2 people so we can have 1 and 2. Now, if somebody says, well, I only want to nominate 1 and I don't want to go with 2, it's their choice, okay? But we must adhere to the commitment that we made to the public and move forward with a permanent CEO on that day. So do you have anything to add to this since you're part of the process and protocol?
Yeah, I mean, that was the mandate that we established. That was the process. I think it's important that, this board can come to a consensus. I hope that there's a consensus there. And I think that process needs to be driven by the 5 members of this board. I mean, I think we want to hear from the medical staff. I want to hear their expressions, their concerns, and their issues may be very different than ours because, we have oversight and governance responsibility. They have a working responsibility. They have a skill set responsibility. They have a medical responsibility. It's going to be different. So I think, it'd be interesting to hear how the medical staff responds to the 4 individuals and their individual time with them, which I think is going to be very valuable in making our decision. And I'm interested to learn that next week for sure. And I'll do that from Florida, so I'll be in the office there because I want to see that in person. I think it's really critical.
Oh, okay, thanks. Well, remember that, I'll tell you the truth from my experience, and I don't know, Commissioner, you were the last of the Mohicans, that's the remaining here, that was through the earlier interviews, and I really feel that we've done well, and these people are very qualified, so we should be able to find a needle in a haystack. So is everybody okay with this?
Yes.
Okay, Commissioner Gresham, Commissioner Yuri?
What am I okay with? I'm not
No, to the fact that each one of us is going
Sorry.
each one of us is going to keep 2 people in mind, 1 and 2 out of these 4 people. And then we're going to listen to the doctors. We're going to listen to who's heading your team over there. Gino is heading the other team. We're going to listen to the leader. Each team has a different leadership, right?
Yes, and so Sandra Todd Atkinson at Medical Center.
We didn't pick it, just
Correct.
you guys.
Yeah, it's the CEO of each of the 2 hospitals, but everyone has been involved, and you have one HR person, Kiara Page, who will help facilitate everything.
Okay, all right. So what I'm saying, come with two people in mind, because if one has a flat tire, then we have to go to number two. And I don't want to go through this process again. I don't want to open it again. I don't want to spend money again doing these things. I want to give Broward Health, I really do, and I mean it, the CEO that we have not been able to give in the last 2 years. You know?
I understand. So just in terms of process, are we not going to have a second round of interviews with a narrowed down to two
Once you get down to the two after we listen to them, okay, then we can make that decision. But it has to be one and two. So,
No, I understand. Just so that, and then if I missed this in a previous meeting, my apologies, but what I had anticipated was a similar process where we would be, at least I was focused on some, let's just say 30 or 40,000 foot level issues in this interview, and in the past we've had an opportunity to get a lot deeper in the second round, and that's at least for me what I had anticipated. So I don't disagree with anything that you've said. However, we owe it to this community, we owe it to the staff, the 10,000 plus people, to pick the right person. And I would say, at least just for me, I think I have certainly some ideas in mind of who I'd like to dig deeper with, but I don't know that at least me personally would have the ability to say that just from the time that we spent yesterday and today. And if I missed that we weren't going to have a deeper dive, then I would have probably insisted on more time and, so on. So I'm not trying to drag out the process, but at the same time, and I'll be happy to do it 2 weeks from now or a week from now, however we publicly notice it.
Well,
I think that what you're suggesting, at least from my perspective, is a big ask, based on hour plus.
well, I just don't remember that, and I'll tell you because I was the only one here then. When we interviewed El Senati, we just went one round of interviews. We came up, we didn't even have a second, because we had one consensus. We had 5 votes on the board of 7, if I recall. And
Well, look, if I'm the only one that,
I just think that we
you don't have to do it my way. I'm not suggesting.
I just think that we need to move the process along, because we need to get this community restored. I believe that compared to what I've been through before, I think that we have a good selection of candidates and we should go move forward. So unless I hear anything.
Yeah, I want to be clear, I'm not suggesting otherwise. I'm just saying that the one time I've been through this process, that's how we did it. And so if it's somehow the way we did it then is different than history, that's just not I don't know that. I can just tell you that was more my expectation, is that opportunity to do that deeper dive. And if we're not going to do that, I'm not
Unless
sure how to get
I hear otherwise, I really feel that we need to move on. This community has suffered enough. We got to move on and get it over with.
Rocky, can I just chime in just very briefly? Especially working in human resources, one of the things that we try and prevent from is the feeling that when you have a candidate in front of you, that it's only in comparison to the other candidates that are in front of you. And really, even in this case, I would say especially in this case, what you really want is the best individual for the health system, and not necessarily the best of the group that you have. So we went through the recruitment process as we have, and we've ended up at this point. And if that particular candidate is the best individual for this health system, then my recommendation is that's the way we should go. If it's not, and it's just the best of the group, then that's a different thing that I would suggest to the board members that we look, further as to, what direction we should go.
I understand that, but here's the thing is, the last thing that I want to see is obstacles, because I remember during the last interview, we ran across a lot of interference coming the other way. In other words, it was from the staff coming this way. I'm not going to get into names or anything like that, but it's time for us to fish cut bait. You got 4 candidates out of 330. And if you think that I would support opening this again, I will never do that. We need to move on.
Well, I think we're jumping ahead of things. I don't think Peter nor I was suggesting real.
Well,
all I'm saying is, we, from my perspective, unless other people think different, and again, I'm only one person, one voice, one vote. I was at least anticipating an opportunity for a deeper dive with 2 folks perhaps.
Rocky, I really think we need to come back next week, hear from the medical staff, and let's see if there's a consensus to narrow the choices down. And I think, let the process play out. We want to be objective. We want to give everybody an opportunity to have their say, but I think it's important that we have consensus as a board. This is an important decision, and we want to make the right decision. And while I can't hear everything Commissioner Uri's saying, I kind of get a gist of it, and I've heard Peter. Maybe it might be helpful I hear, Commissioner Klein's a position as well. I think maybe all of us should share that, whether or not we can come to a consensus next week. Let's see where the process plays out. Let's reset it.
Well, that's what my intentions were, to get ask everybody to bring, 2 of these 4 people, come back with 2 in mind. Now, if you don't have 2 in mind, come back with 1, but come back with somebody. You follow me? And I said, after we listen to the medical staff, and after we listen to the leadership staff, okay? Because I've been hearing all kinds of stuff out there that I really don't want to go through, and I'm not going to get into that now, So.
But Rocky, failure's not an option in 2 ways: us hiring the wrong person, or us not hiring the right person. So I think let's let the process play itself out. We have done everything we said we were going to do. We have attempted to find the best candidate or candidates for this. Let's get the input from the medical staff, and let's see if the board has consistent, has some kind of consistency in thinking. And if we can come to a consensus, that's a great decision. That means you've got 5 really, focused people making a decision as a group. Let's just see how it works out. I'm not trying to be difficult. I just think we don't want to predetermine one way or the other. We know what our mission is. We know what we're attempting to do. Let's get the input we're looking for and see where we are next week. And I think, we'll have some answers.
All right, so
I agree.
I agree with you. I don't have a problem with that. I just want to say, we said we're going to go do this, and they're going to come in and make their recommendation, and then we'll figure out what we're doing, and then we'll see. Maybe there's only one person in this group that'll fit the pattern. But I did not say that we're not going to listen to what they have to say. I think that you heard me clear on that. We want to hear from you, but I got to tell you, this community is up in arms about 2 years without a CEO, and we've done this twice. And the last perfect human being in the world, you know what happened to it. Anyway, so.
Well, at this point, we have a CEO. you know, I think a process has been established,
Right.
you know, that by the CEO search committee, you know, by Mr. Chairman and
Right.
Commissioner Wellens, and I think that we have followed that process.
Right.
I came in during that process as a commissioner. My understanding was that we were going to evaluate the 10 or so finalists that were presented, narrow that field down. We did that. We narrowed it down to 6. 4 outstanding candidates came in. We vetted those folks now. My understanding is we were going to meet, take the input from the medical staff and from the executive team, consider that, and then select the CEO. You know, if there is a qualified candidate, select that person as our next CEO. With, I guess what you're suggesting now is selecting an alternate, a fallback person in case the first choice is not available, which I think makes sense. Since we're convening in open meetings, we have to have an open process to do this, to select a secondary candidate. But I'm comfortable moving forward with the process that has been established. I believe we're supposed to meet next week at 1 p.m. to have that discussion. I look forward to getting the input from the medical staff and from the community and from the executive team, you know, in their perspective. But fundamentally, one of the most important responsibilities of this board is to hire CEOs, to hire the certain senior leadership positions. And I look forward to fulfilling that responsibility.
No, exactly. You know, we're right back on the same page. So, all right, so is everybody okay with it? Okay. Thanks. Thanks for all your work, by the way. Are you there?
What's that?
I said, thanks for all your work. You drove me hard.
Everybody does all the work. I mean, everybody's done a lot here, and hopefully we don't have to go through this process again in our careers here at Broward.
I won't be around. Trust me. Okay.
Motion to adjourn?
Motion to adjourn.
Second.
All in favor?
Aye.
All right, so we adjourn.